Sue, did you have your hand up?
I was just going to say with switching, I have to leave. I have a 1 o'clock, so then I can't participate in the breakout. Doesn't probably make any difference, but just a heads up.
Thank you.
Okay.
So just to let everybody know that we are recording today's session, it will be stored on our Canvas site. By being and participating in this, you are consenting to be recorded. Echo, we hope that you make this interactive and participate in that. That means renaming your profile, taking a minute to turn on your cameras. There is that raise your hand button. If you find that, we'll call on you. If not, you can also put information into chat or just unmute yourself. Please remember when we're talking about anybody to protect individual privacy. So avoid using any information that would help us identify who that person is. If you are unsure of that, please reach out to any of the hub members. They all have an asterisk in front of their name, so you can find them easily in the chat. If any of you haven't participated in an echo before, please know that echo is really that participation. So ask those questions, communicate to your other participants that are joining, turn on your camera so we can all see and know who each other are. Case narratives are also a great way to get information about difficult cases. Learn from each other. So if you are ever interested in doing a case narrative, please reach out to Project Scope at usu.edu and do a case presentation. The key components of an echo are really building that community of practice, so that knowledge sharing. We have a didactic speaker, and then we do a case presentation where we generate a ton of great resources and provide feedback for the case. All of the recommendations will be stored on our Canvas site. So if you ever want to go back and say, what did Tressa tell me about that? You can go and find that for future clients. A way to get the credit for attendance is the surveys we send out. If you've joined in the past, we usually sent them out through Qualtrics through a separate email. We are moving to, we used to send them out with RedCap. We're now using Qualtrics. And we will put it in the chat for you guys to take during the session, but it will come out with the follow-up email. So hopefully we will get more of those back. They're a great way that we can keep these sessions free, get information, and that's how you get your credit for attendance. Each of you will be receiving a Canvas invitation to find recordings, PowerPoints, any of those recommendations that we shared during the session, and any way else that we have, any other information. You can also use the discussion board to ask questions as well. We have a great social media where we share information and upcoming sessions. So if you haven't followed us on social media, please take a minute to do so. I am really thrilled today to introduce Dr. Sarah Winters, who is going to be sharing with us today about child development, and she has a wealth of information. So I'm going to just stop sharing and allow her to take the time over.
Well, great. Thank you so much. I hope that you would stop me for any questions as well as any kind of tech issues if you can't hear me well. How is it going so far, Janelle? Are you able to hear us clearly? Okay. And with me in my room is one of our Lynn trainees. Teresa is from actually Wyoming at Laramie, where Scope Project has relationships as well. So that's been a fun connection. We're all interconnected, right? In this world. So I'm going to share my screen and get to the talk, which actually, I don't know how that Oh, here. So there we go. So today, Janelle had asked me to talk about the role of the developmental pediatrician in the care of children with neonatal opioid withdrawal syndrome. My hope was more to really get you to understand at least how I think of and maybe how developmental pediatricians think about the problem and their evaluation of children. The other hope I'm trying to get across is like, which of the kids do you think would need developmental pediatrics consultation and which of the kids might not need that? And then finally, I really want to be open to any case discussions or questions you would have of either me or the University Developmental Assessment Clinic, which I'm the medical director of. So feel free to expand your questions to what other people that I work with do in these case situations. So I have nothing to disclose. And in preparing for this, and by the way, Janelle, thank you very much for asking me to do this, because anytime, I don't know if you guys have had this experience, but when you're asked to give a talk, there's a certain amount of, oh boy, this is going to take some time to make sure that I'm, presenting things well. But then after a while, you're like, oh, this is really interesting. I'm so glad I got to learn about this. Part of my investigation was finding this statement that is a joint statement about the kind of the state of things. This is in April of 2016 that they got this committee together and really looked at key areas and trying to identify the knowledge gaps and review the evidence for the management of opioid use in pregnancy and neonatal abstinence syndrome. You can see the areas I highlighted these experts tried to address the research gaps, and you can see items 1 through 5, with 5 being what are the long-term effects of prenatal opioid exposure in children. And what struck me about this consensus statement or the executive summary was this is the shortest part of the report. I mean, actually, it's like 1 paragraph, which to me tells me, yeah, we don't really know what the developmental outcomes are for children who've been exposed to opioids. And that, that was essentially their conclusion. Now, I know April, in my mind, I'm thinking, oh, that was recent, 2016. And then I think, oh no, that's actually now 8 years ago. So I guess it's not that recent, but it hasn't been reconvened. I didn't find an updated report about this. So, but it's a nice overview. I looked at other studies trying to find out, well, what do we know about the outcome of children born with opioid withdrawal syndrome? And I found 2 polar opposite papers, which is, it's no surprise. So the first one was in a Journal of Psychiatry, and it was a meta-analysis of studies. And basically, its conclusion was there was no significant impairment in neurobehavioral outcomes when compared to non-exposed peers, although in all domains there was a trend toward poorer outcomes. So they were in general seeing some poorer outcomes, but didn't reach significance. Now, you contrast that with a more recent study that was presented at ASHA. So I wasn't familiar with this publication. It was Perspectives in ASHA Special Interest Group. So this is a group out of Nationwide Children's Hospital in Columbus, Ohio, and they looked at infants with neonatal opioid exposure, and then just 1 year later. Obviously, the other studies were looking at much longer outcomes. They looked at 1 year later, and they used the Bayley-3 scores for cognitive language and motor, and they were all lower in this group. So, there you have it. It's one says no difference, one says yes, there's a difference. They're obviously completely different cohorts and different ways of looking at outcomes, but that's the general feeling that I got from the very small literature. If you look on PubMed, this is didn't take a lot of time to look at all this. What I am impressed with is what Janelle has put together with this SCOPE project and this ECHO. I had a chance to review many of the presentations, and I think many of you were on these other seminars, but if you haven't been, I think it's worth going back to some of those and watching them. I learned so much. So one from Marcella Smith, the physician from the university, has a really nice overview of treatment. The one that Dr. Camille Fung did identified the problem in infants. So Marcella's working with the pregnant population. Dr. Fung's working with the babies, and she did a really nice job of saying how much more kids they're seeing in the NICU. And this morning, actually, we had a resident with us, and she was saying on last month they had many children that they were managing with neonatal opioid withdrawal syndrome. So it's kind of a sobering and sad talk, but if you didn't see Dr. Fung's, it's really worth going back to. And then Heidi Peterson did a really nice job of thinking like upstream prevention of this, definitely worth thinking about and talking about. And then Janelle did a nice presentation about, okay, so, you know, what happens with toddlers, and all of these things that you see on this list are what they're, you know, what's being seen. And you all know that. I see many of the names on this group I recognize, and I know you know this. So, but Pat Boyle, so glad to see you doing this talk on sensory issues. So we know that kids have sensory problems. We know they have real challenges in communication. And if you want to review that, Jamie Mitchum did a nice presentation on that. But those are the experts that I lean on to actually evaluate and develop treatment plans. But part of this is just wanting you to get a sense of, how do I think about these kids who come to me with these concerns? And it's really, essentially, it's just like any other child I see. I am trying to integrate the prenatal history, the perinatal history, the postnatal history, the family history, medical history. So all that stuff that we all learned is so important is still key, because a lot of these kids could have other issues that have nothing to do with the opioid exposure. You know, and then since birth, while they're, you know, with me trying to review their surgical history, any other medical subspecialists they see. And then I do my developmental evaluation to best understand where are this child's strengths, what are their weaknesses. And then I develop a plan for further investigation if I need to, or recommendations for intervention. Now, to be honest, the kids that I'm seeing, they pretty much all need a further investigation. Because, well, one, I'm not that smart. Two, these evaluations take a huge amount of time, as you know. It's really hard to get a sense of the whole child in a 2-hour developmental pediatric evaluation. But I kind of see myself, and for those of you who are musicians, this analogy might resonate more than those of you who aren't, but I did orchestra in college, and I always think of the role that I'm playing here is like an orchestra conductor. I need to understand the music. I need to understand the history of it. And then I need to understand each of my the players in the orchestra. And I need to say, okay, a little bit more trumpet, a little less bass, a little less drums, more flute. That's what we're doing in developmental peds, is trying to be like, not an expert in any one of these things, because some of you are those experts, but trying to recognize, how do I connect this child to the expert that this child's symptoms require? I apologize for the colors on this. I know they're all wrong for an accessible PowerPoint, but it changed all these colors. So if you can't see the yellow, I'll walk through it. But so this, to me, I like this Venn diagram, because it's kind of how I see neurodevelopment in a child, as well as it helps me understand what my role is. I need to, before I get to a medical evaluation and diagnosis, I need to conceptually understand that there's a lot of ways a brain can misfire or do things differently. And a lot of these areas are overlapping. It's not like, it's rare that you see a child who has just one area of the brain that's not working very well. But if you think about these concepts, there's, you know, the concept of cognition, there's problems of cognition, and your prototypical disorder in cognition would be cognitive impairment or learning disabilities. And I see that I have MR, and I apologize that that should not even be on the slide. I've seen it so many times, I didn't notice that, but it should be ID and LD. the quintessential movement disorder is CP, but there can be other movement disorders like, developmental coordination disorder, or just like a primary a muscle disease. But cerebral palsy would be my example of of a movement disorder. And then there's problems of sensation, so hearing and vision impairment, problems of behavior, ADHD, and problems of social skills. And as you can see in the center of this, you could have a child who has everything. They could be cognitively impaired with cerebral palsy, hearing impairment, have ADHD and autism. And, I know you all know this, but this is how I think of it. When I'm trying to do my evaluation, I'm thinking, which areas do we need to address in this particular child? Then I'm going on to thinking about, okay, in every kid, every situation, I'm always thinking, doesn't matter what the chief complaint is, and by chief complaint, I mean like the referral question. What are their gross motor findings? What are their fine motor findings? What are their language? And apologize to speech therapists out there, because I am very basic about my understanding of language. I think of it as expressive and receptive, and I know it's so much more than that. And then what are their social and behavioral findings? And that is going on in my head all the time. Oh, there's like graphics with that one. So gross motor exam, I am thinking about all the traditional parts of the neurologic exam. So the things that, we were taught. What is the motor strength? What's the tone? What are the deep tendon reflexes? And then it combines it into, with children, we have to think more about primitive reflexes. We have to know when they're supposed to be there, when they're supposed to go away. And that's not something an adult neurologist has to think about too often, although sometimes they actually do. What are the postural responses? What are the quality of the movements? Like, is there ataxia in there? Is this dystonia? Do we have problems of asymmetry? And then, how has the child acquired the motor skills? Or, did it go along normal and then plateau? Or is it going along slowly? If normal is here, this child's here, going more slowly. And then obviously there's some kids who have like developmental differences, some real atypical ways, like that kid that's arm crawling by pulling just one side of the body along. All of those things have to be in place before a child can get up, walk, and run in a smooth and coordinated fashion. And I know like that might seem not pertinent to a child with like, if you're considering autism, but a lot of kids with autism have a motor component to their problems too. All the while I'm looking at those things, I'm also looking at what's the level of skill they've achieved, what's the postural control, what's their gait, and what's their symmetry. This is all going on in my head as I'm watching this child walk down the hallway or run. In the case of this morning, Teresa and I saw a very active 18-month-old who we had to chase down the hallway. It was very cute. And these are just quick things that I know you all know. Goodness, Pat's probably falling asleep at this point. But a 3-month-old should hold their head up steadily and support themselves in prone. I always say, this is why you get 3-month-old baby pictures. Like nobody sends 2-month-old baby pictures because they're 2-month-olds or their heads are flat on the surface of the bed. So it's not until 3 months old that the parents can get that really good shot. A 6-month-old can sit up, a 9-month-old pulls to stand, and a 12-month-old in general, I mean, that's a median, is walking alone, but they have that wide-based gait. 2-year-olds can walk up and down the stairs without help, although not in the adult fashion, and 3-year-olds can pedal a tricycle. 4-year-olds can hop and skip. So that's why I'm always running kids up and down the hallway, much to the chagrin of our cardiology colleagues. We probably are interrupting their clinic a lot, but they're used to us. And our kid this morning was fun. They laughed with us, so that's okay. Fine motor exam, I'm thinking about the same things: level of skill, postural control, symmetry of motion. So things that that make you worried is, but you have, and this is where you have to know the developmental and chronologic age of the child, as well as adjusted age if the child's premature. So fisting's okay at infancy, but it should be gone by 2 months. Grasping patterns we think about all the time. Our OTs are excellent at this. 4-month-olds can bring their hands to midline. It's this kind of thing, like this has to be ingrained in your brain to know, if this child is off. So mature pincer grasp we're looking for, and the child who can hold the marker and make dots on the page and scribble is what we're looking for in an 18-month-old. 3-year-olds can copy a circle. That's kind of ingrained in my brain and an easy thing to test. And I love block design. I'm sort of spoiled now because at UDAC, as Teresa was able to see this morning, I don't have to do this testing. This is done by our therapist that's in the room with me. Not all developmental pediatricians have that luxury. And so some of them will do the test themselves and use a variety of different standardized tools. The CAT clams, I don't know if you guys are familiar with that one, but that one's actually got pretty good psychometric properties. But as Tressa knows, hi Tressa, thank you so much for your referrals. There's like at different ages of kids, there's different ones that show better, like, for beginning infants, the TIMP is really good, but then that, it ages out at 4 months. The Peabody is good, but it has an optimal age. So I actually don't know all those tools. I get to know 1 or 2 of them well. And that's where working with excellent therapists, I am just so fortunate because they keep track of all the scores, and I can I think the most important thing for pediatricians is knowing what a score means and knowing what the test will actually tell you. Now, language skills, there's so many tests on language skills. And of course, Jamie probably went over those better than I could. But I think of, just knowing words, expressing words, but then also considering the whole language component is a much more sophisticated skill. So when I see challenges in this area, again, I am very spoiled. I have easy access to speech language therapists who are very excellent. And we, in general, in Utah, we have that all around the state. But that is not easy to come by in rural areas. So it can be a challenge. Psychologists can really help you with the language, but honestly, I found that even psychologists really need that backup of a good speech language therapist to understand which component part of speech is the problem. And then, as you know, and all of you do, social and behavioral observations continue from the moment you get a flash of this kid walking down the hallway till the moment you leave the clinic room. I'm always thinking about, the social and behavioral skills of the child. I'm thinking about how are they dressed? How well are they cared for? What kind of, is the child not tolerating the texture of the clothing that they're wearing? Are they looking at me? Are they looking at the caregiver? Did they have joint attention? Did they point at something? All of those things that you have been trained to notice. Obviously figuring out if a child's anxious or depressed is hard in a clinic setting. I don't know if you guys seen our clinic, but it's a clinical place. It's not like ideal for developmental evaluations. We look like the place that the kids are going to get a shot in, to be honest. I have had plenty of kids come in, and if they're old enough, they say, no shot. And I say, no, we're the fun place that, but it's a little hard to convince them of that when they see the otophthalmoscope on the wall. So some of you have better environments to test a child and get more of a sense of their social and behavioral. And actually telehealth has helped us with that quite a bit because we're doing a lot of testing of the kids in the home environment. So we get maybe a better picture of their social and behavioral skills. So coming back, okay, so that's my evaluation that I'm thinking about. And then I'm always thinking, okay, so what areas? Is it the cognition, or is it the social problems? Is it more movement difficulties? Do we have an impairment of hearing or vision in this? And, what's the child's behavior like before I get to, a plan for intervention? So in my head, I'm always thinking, like a systematic approach. How do we deal with these kids? Because all those talks before, like Marcella's talking about the treatment of the pregnant woman, the Camille's talk when she was talking about the problem in the NICU and newborn nursery, and all the beautiful new protocols I learned from our well baby nursery head, that they're doing the eat sleep console process, and Camille talked about eat sleep console. I mean, that's just a great way, and it sounds like really effective. And it was great to actually review this, Janelle, because I found out, oh, we're doing the follow-up visits. I didn't even know we were, but it prompted me to email Camille and go, I don't remember this study. And she goes, yeah, you're already seeing these kids. Like, okay. I knew we had some kids coming in and they're called blinded study patients, and it's them. I just didn't realize that the blinded study patients was the eat, sleep, control protocol. So thank you, Janelle, for forcing me to learn that. So we're going to be looking at those kids. And I really feel like all those things are great, but we all know it's not gonna save every child from developmental problems. So turns out our skills, because I can see all the skills of you on the screen, are still going to be needed for these kids, because as Camille was discussing in her talk, we actually don't really know what's happening to the brain. Like what are those opioids doing to the fetal brain? Camille's trying to look at it in mice, but I think we're pretty far away from knowing exactly the mechanism of damage. And then, as everybody knows in this group, the confounding factors are so enormous in this group. So even I believe the reason we don't have that much data in the literature is because this is a very difficult group of folks to study. We, for example, are involved we were involved until it became not feasible in a study of looking at developmental outcomes for exposed children, and half the patients didn't show up. And it just was a model that we couldn't maintain. We had to hold appointments, and we missed revenues from that. And so we unfortunately had to tell the PI, we're so sorry, but we can't keep doing this. We can't keep following or seeing kids that don't show and then losing productivity for our therapists. So I know there's other studies being planned. There's a study using the research network, a protocol that's out there to look at developmental outcomes at 2 with the Bailey. And it's a big nationwide study. So I feel like 10 years from now, we're gonna have more data, but right now there's like none. So you just, like any child, you have to just say, okay, well, let's see what the issues are and make a plan for intervention. And that's, the main things I wanted to discuss. And I thought maybe that would generate some questions or cases or any additional thoughts that you guys might have. So can I open it up now? I'm going to stop sharing my talk, and I wanted to open it up to more of a discussion model. Oh, Natalie Allen, I see you on there. Yay. This is so fun. And Sue, and there's Pat. Oh my gosh, so many people that I know. This is great.
So you can either put your questions in the chat or just unmute yourself and ask Dr. Winter any of your questions.
How about I start? I'm going to ask Pat because she has so much experience with this. I see your name so often, Pat, that I feel like it's been 16 years that I've been here, and we've never been in the same space. Now we've been in Zoom calls, but do you feel this like an epidemic of this, or do you feel like, no, it's kind of a steady group of kids that I've always seen, and they're always, or is it ramping up in terms of the problems that you see because of?
Well, I just have anecdotal experience.
Oh, that's okay. That's all anybody has. Honestly, there's no data out here about this.
Because I go to the NICU, I go to the biggest issue is our level 1, level 2 nurseries where, the focus is let's kick them out after 48 hours. So I think we are always burdened with that. And I know there's so many different systems that are trying to attack that. So my question was going to be, can our follow-up clinics pair with our social service people? Because they're a consistent input in these families' lives. And I can see this kind of family having more issues in their lives than attending a follow-up clinic. I mean,
Yeah.
I think they get overwhelmed.
Yeah, and I mean, Pat, you embedded in that was the thought that Karen Bushai and I have been talking about for years, which is, could our neonatal follow-up clinic, and by the way, I'm the medical director of our neonatal follow-up clinic, which is within the University Developmental Assessment Clinic. The kids that currently, the qualifying criteria for our babies are less than 1,250 grams, less than 26 weeks. I know it seems like, really? Wow, that's pretty little and pretty young. But if we expanded to 28 weeks, as it used to be 20 years, well, probably 25 years ago now, the numbers would be overwhelming. And 15, it used to be 28 weeks and 1,500 grams. And Natalie Allen was, I used to work with her in the follow-up clinic. It was so fun. Anyway, we have talked and talked and talked over the years about adding that opioid exposure as a criteria for the neonatal follow-up clinic. But I have been somewhat reluctant to do that without the social supports, because we
Yeah.
don't have a social worker in clinic.
Well,
And
do you know that the therapists, well, at least the therapists that I work with at Intermountain are doing a GMA on a lot of these high-risk kids.
yeah,
They automatically get qualified. So that's one way, but are they catching everybody?
are they catching everybody? And do those kids have an abnormal GMA? Because that would qualify them if they had cramps synchronized. Pat, why don't you do a little 2-minute spiel on what is a GMA? Because I'll bet you much of this audience might not know what that means.
I'm pretty sure they do know.
Do they? Well,
Because a lot of the early intervention groups have been Lauren Ayala presented to us, but it's just the general movements assessment, and it looks at atypical movements in a developing preterm infant up to, I think, 4 months. I mean, I don't.
Yeah,
I took
16 weeks post.
Yeah, I took the training, but I certainly don't implement it. But it's interesting because that's the group of people, those kids, I mean, they can have some pretty bad movement patterns.
Okay, so that would be a way for a slice of that group to actually qualify for our clinic, because cramps synchronize. So just so you know, you can imagine, so an infant is supposed to be writhing, have these normal writhing movements as like a newborn. And when they move like this, that's a cramp synchronized, and we don't like that. I think most of you guys would look at a baby like that and go, "Ooh, that doesn't look right." Hopefully. So when a baby has that type of movement, that's a qualifier for our neonatal follow-up clinic. But I know that a lot of those babies probably, maybe they have poor repertoire. It's like a gray zone result, and those kids wouldn't qualify. So I would love it if we actually had a clinic, and there is discussion about it. We actually had a faculty member, a recruit that wanted to do that, and she didn't end up coming. So that was a bummer. Literally, we would need probably twice. We'd probably need 1 day a week more than we have to accommodate the numbers of kids. And I would love to see that happen, because the kind of follow-up we do. So in the neonatal follow-up, we see the kids at 3 months, at 9 months, and at 18 months, 2, 3, and 4. That might not be the right schedule for these kids. Or if we were just focusing on the development, maybe that would be okay if there was also another clinic that did more frequent early visits. But I worry that that's too far away for a kid who's really irritable and hard to care for. Don't you think, Pat? That might be a problematic schedule for them. Not enough follow-up.
Well, they get referred to EI because
So
EI has that requirement.
that's
They
true.
have that as on their eligibility list.
Yeah, and that shouldn't be a reason to say that they just because it's like never met. What is the saying? Never let the enemy of never let perfect be the enemy of good. And I sometimes think, well, it would be better to have them in our less than ideal follow-up schedule, which is actually pretty good, by the way, as follow-up schedules go. We actually have a pretty rigorous neonatal follow-up clinic. Sorry, I have pinging thoughts. One of the the wonderful things about our follow-up clinic, it gets back to Jamie Meacham's talk, is we have speech language therapy in our clinic, and that is a major problem in our follow-up population. And most NFPs do not have speech as part of their clinic. So we're pretty lucky that way. I don't know of any other clinic that has a speech language pathologist in their clinic, in their follow-up clinic, I should say. So we're lucky that way.
Well, I just wanted to get back to, is there a way to pair with social services, like with
I know.
CFS? Because with the Eat, Sleep, and Console, Camille was saying that the problem was HIPAA, or no, it's not HIPAA once you're discharged, but it's more just how do we access these kids once they get out of the NICU and the nursery?
Yeah, I know it's such a challenge to try and that sort of relates to Crystal's question, which is how can early intervention collaborate with the Act not to overwhelm these families? Because I'm thinking about where are the resources of social service, what agencies do those land in? So it's child protection, it's early intervention, and tell me what kind of social work support EI has in Gen. Is that none at all, or?
Well, I know for our program, we have social service workers that pair, and I don't know about other programs in Utah, but in other programs in the United States, their service coordinator is a social worker.
Social worker, okay. Because that's something we don't have, and I don't love that about our follow-up clinic. I was listening to a presentation by our Neonatal Research Network and found out that Atlanta has a social worker in their follow-up clinic, and they're doing that ACEs screening questionnaire, and they can respond immediately in clinic. There's food insecurity, here's a grocery bag. They literally have, those food bank grocery bags. And here's a grocery bag. Oh, you don't have housing? Let me get you, we can send you in a cab over to this place. We don't have that in our clinic. I wish we did. So that's it makes me anxious about doing an ACEs survey in our clinic, because I don't want to find out information and then not be able to do anything about it. In their Atlanta group, 25% of their NFP or their follow-up clinic needed something from their 25%. And I have no reason to think our clinic would be different about that. Now, in a NOWS population, it's like, I'm guessing it's 100% need social service support of some kind. And we don't have that in our clinic. We have connections to EI, getting back to Crystal's question. How can we collaborate with early intervention? Give me ideas. How can neonatal follow-up help?
I'm wondering if we'll see how the session ends, but there is some proposal for expansion of parents as teachers statewide through home visiting, which that could be a route in. I mean, I come from child welfare. I would prefer to keep us out unless we have to, because the second we get there, the odds of separating that dyad get larger. So, I mean, obviously there are times when that needs to happen. But I'm hopeful that the funding for the expansion of home visiting, that's, evidence-based programming that connects to a lot of those other services you're talking about, like being able to get food and help with housing and transportation vouchers. One of the big things that we're seeing that overlaps a little bit is these kids then afterwards come to child welfare attention for medical neglect. And a lot of what we see when we actually do respond with a CPS investigation is it's a lot more access and understanding than it is actual willful neglect. So transportation issues, I'm working 3 jobs and the clinic is only open so many hours, and so it's easier for me to take them to the ER, like those sort of pieces, rather than willful parent neglect. So that is a huge gap. I would agree that there's not really a great like social service connection for how do I actually get to these follow-up pieces? How do I actually get my kids where they need to be when I have no way to get there, or it's going to take me 4 hours by bus, or like some of those pieces.
Kyle, I think your talk was great as well. My thought when I was listening to your talk is, as a development, trying to think about this, the purpose of this talk is how do I function as a developmental pediatrician? And I was thinking, your talk reminded me that I need to know, and my colleagues need to know, what systems are out there in place and how do they function? Because sometimes I think, as I'm teaching pediatric residents, they have an unrealistic understanding of what the service is. And so that they'll give guidance to a family and I'll go, no, that's not how it works. And so thank you for your talk, because knowledge of systems is super important as a developmental pediatrician, and keeping your knowledge up to date and accurate. It did make it, what you said reminded me that our integrated services program through the Bureau of Children with Special Health Care Needs is supposed to help with that kind of stuff. So I can call them, or our team can call them if transportation is an issue and they need vouchers. I mean, it sounds great. I mean, sometimes it's impractical. Like, you can get reimbursement for your gas money, but it doesn't come until 3 months later after you filled out, 4 forms. Not that I'm exaggerating, but sometimes even filling out 1 form is challenging for the family. And so reimbursement for travel expenses to our clinic is not as easy, I guess, as we would say. But that's a system. It's in I like the home visiting nurse idea better, and improving our funding for that, because I think that's a person in the house who sees what's going on and understands the medical complexities of these kids. I think if we could fund, like as a society, we could increase funding. Obviously, everyone on this call believes in that would increase early intervention, preschool services, and home visiting nurses. That to raise this whole, problem up. There's still going to be kids, though, who have all that and still have significant disabilities. And those are the kids that need to come to our clinic, because they need very specialized evaluations and specialized interventions. Or they need to come to Natalie as she turns her camera on, because this group probably knows what you do, but maybe somebody doesn't. I mean, you're out there. Tell me what you're doing now, because it's hard to keep track of where ISP is.
Sorry, I'm having computer problems. So, I'm talking to the IT guy, but anyway, so first of all, I was so happy to see your face today. It's good to see you, Dr. Winter. I work for Department of Health Integrated Services Program through the Department of Health and Human Services. And I have care coordinators in many rural areas: Blanding, Vernal, Price, Moab. I don't know, I'm missing some of them. And some of the kids come to us who have diagnosis, and some of them don't have diagnosis, and we can assist with either end of the spectrum that you're on. I'm also available to support kids throughout their journey. Dr. Winter talked about, leading the orchestra, and that can get very tricky for parents, when to increase services, when to decrease services. What can we do differently? So I just can assist. My care coordinators are assigned to patients according to where they live. And then I'm able to see them by telehealth. I also do go visit clinics, not as regular as I used to, because telehealth is awesome. And I can, meet families in the evenings and on the weekends. So anyway, I just do a little, I'm, jack of all, master of none, except for that I was trained by Dr. Winter, and I feel so proud of that.
I feel like that too. How can we be so subspecialized, right? Like, I'm a neurodevelopmental pediatrician. That sounds like, a tiny slice of medical world, but I still feel like I'm a jack of all trades, master of none. Like I know enough about speech therapy to understand when the speech therapist talked to me. I know enough about what the physical therapist is saying to translate it to the parents. I know enough of what the psychologist has done to understand that, you know, the child skills is thus, but I can't do any of those evaluations. But I kind of like that about my job. Honestly, I love interacting with all these different services and understanding, you know, what does, you know, Tressa do? What is, you know, what does somebody like Jamie Meacham do? And Pat, oh my gosh, I keep having to remember she's a PT because she does everything. But I know you're a doctoral in PT, but she gave the talk on sensory problems. So, but I don't know that much about sensory. I know enough to say, gosh, does this child have a sensory problem? Maybe I need to send them to, you know, her OTs. So that's a cool part of the job. And I think the other part of my job as a developmental pediatrician is to think systems wide, which is what SCOPE is about, is trying to figure out, we got a problem here in the United States, and how, you know, how do we bite off this huge problem? I mean, honestly, did you all feel listening to Dr. Fung's talk, like kind of depressed? When I saw those really dark areas of density of problem, it just is so overwhelming. And I just worry about this group of kids, because they're going to go out and make, you know, for those who have a lot of neurocognitive issues, they're going to go out and make kind of poor decisions and perhaps bring another generation of kids into this world who are going to make poor decisions, and on it goes. So to me, part of our work, which is the whole reason that you all are here, is to think bigger thoughts than the one-on-one patient interaction, and to think about advocating for public health, you know, and home nursing, home nurse visits as a way to address this, and prevention. You know, I mean, Heidi's talk was lovely, but you know, a wonderful enriched home environment, how do we get that for some families? How do we do that? How do we keep the families from even getting to the point where they think that drinking and taking drugs is better than real life, you know? That's, to me, that's the bigger question of it all. How do we solve that as a society? And I know SCOPE is trying to look into that, but you know, in all of our job titles, we also have to think about our systems to deal with the kids with the actual developmental delays that are already here.
Yeah, and I really appreciate, Dr. Winter, where you're saying you get that whole story, that whole concept of what's going on with the family. And so I think that that's a great approach of one of the things that in early intervention we can add to and help support with that, as well as work on that system. So I really appreciate you taking the time and sharing that perspective with us.
Yeah, I always wish like I could. It was one of the things with telehealth, and Nellie, you probably had this experience. I've had some of the therapists there at the telehealth appointments, and wow, has that been a great experience. Then we can know what, you know, like our therapist can talk to their therapist to say, this is what we're working on. Oh, that's great. You know, we're trying to decide about a brace, or we have ordered the wheelchairs, it's not here yet. And, you know, those kinds of communications are so important. How to make that easier, that's the challenge, because of our darn, you know, privacy is important, absolutely, but it's just a challenge in between medical records system.
Dr. Winter, don't you think telehealth has made it easier though? Because I do co-visits now with my OT and my speech and my care coordinator, and we're all in it actually is, it's been very helpful to have that component for us to be able to do that. We don't do our neonatal follow-up clinic, but we sort of create that in telehealth. Yeah.
And you know, we're doing some of our neonatal follow-up clinic visits over telehealth too. Oh, you didn't know that? Yeah. So yeah, it's, you know, pandemic just was a fruit basket upset for everyone. And we the funny part, I can remember that first day going, well, can we do this? And we did it, and we were like, okay, this worked. And And then we're like, yeah, but we can't do the Hind. There's no way we can do the Hind, the Hammersmith infant neurologic exam. And then we're like, well, yeah, a parent can lift up a baby and tip them this way and tip them that way. And they can do the parachute if we showed them. And turns out we can do a standardized neurologic exam. The parents aren't great at the reflexes. That's the only thing we fall down on. So we've done the Hind now for 2 years over telehealth, and it's been really fun, and parents do a great job at it. And we get a standardized score, and then we're using the DAISY. I don't know if you guys are using that tool at all, but the Developmental Assessment of Young Children is actually it has fairly good psychometric properties. There's a cognitive component and a fine motor and a gross motor component to that tool. It's the speech therapists feel like it's a little bit too basic, but it still holds up under psychometric testing. They don't love it for the language component. But all the other components, it works pretty well. And it's a combination of observation and parent report, and it doesn't take that long to do. Allison Elsie is the other developmental pediatrician in our clinic, and she's been doing it on some of her telehealth visits for CDP when necessary. She does more like autism testing. So that gets me to another subject that you guys may be interested in, is our telehealth process of autism evaluations has just just expanded and blown up. I mean, there's everybody scrambled to figure out how they're going to do autism over telehealth, and now you're getting into the time frame where people are doing studies about the sensitivity and reliability of those tests, and they're starting to get more like firm ideas about which of the kids does it work well in, which of the kids does it not work well in. And as a clinic, we're trying to discuss, how's that going? What are we going to do? So, for example, all the psychologists feel pretty strongly that 4-year-old girls are not good candidates for telehealth. Apparently that just falls apart. They don't do well. But your 2-year-olds, like 2 to 3.5, it actually works better over telehealth. So I think we're going to get more data about that sort of thing. Bye, Sue. I have to leave. So good to see you.
Yeah. And that's an amazing thing. I think that, like you mentioned earlier in your talk, as children that have neonatal abstinence syndrome or withdrawal syndrome, they're going to find out more research about what are the implications of it. I don't know why I struggled with that word. Same thing with telehealth.
Yeah.
And I just really appreciate your points on it. I am going to wrap it up and let Tressa go ahead and present her case with us. And if you guys are free to stay and discuss with us, that would be fantastic.
All right, thank you. Hang on, let's see if I can get this to go. Hang on, I gotta move the toolbar here.
Is it working, Tressa?
Yes.
If you go, yeah, right there.
Okay, so we'll just skip. I'm Tressa Johnston. I'm a physical therapist with early intervention, and I'll be joining the Institute for Disability as an associate director of service with Kurt. The case that I am presenting today, I'm actually was working in the home with the younger sister. So the main case, though, is about the older four-year-old sister. Let me see if I can. Who was exposed to meth and other substances in utero. She was removed from the home while she was in the NICU. She then went into foster care, and the foster family adopted her. The foster family then was given a guardianship of her younger sister, who was born a few years later, who also was positive for NAS and NOW. And so that family continues to plan on adopting the younger sister. But while I was in the home, we really get a good look at the family and kind of other things that are going on in the home that the family may need help with. And we talked about the older 4-year-old sister who is participating in special education preschool with languages services through her local school district. And the main concerns were behavioral and emotional self-regulation. She was, like I said, receiving language expressive services and articulation delays. When she is upset, it can take over an hour for her to calm. Typically, it was closer to 30 minutes up to an hour, but could be longer. She required lots of transition and prep time and cues. They had a particular structured routine to help her with prepping for the school bus, of watching out the open door, but standing at the open door, then moving to the front porch and standing and waiting, and then being able to, when her mom could see the bus coming down the road, then they were able to walk forward. But it was a very particular routine, because with any change in it, she would have meltdowns and have a really difficult time recovering. As the things that we discussed was, did the school know that what the exposure to the substances in utero that the 4-year-old had experienced? And the parent was fearful of labeling, so none of that information was passed on to the school. So we kind of talked about like other ways that the school could help as far as outcome measures and looking at self-regulation, calming skills in conjunction with the language services she was already receiving. And we discussed that the family kind of talking with their pediatrician, looking for more testing at UDAC or another facility. I really like the team approach that Dr. Winters uses. So I have a tendency to encourage families when we need a broader team perspective. We discussed looking for play therapies or other therapies that might fit the family's cultural and values. And we looked and discussed different ways on helping that child to identify feelings, looking at like printing off some emoji faces or child face boards for her to be able to pick out when she's happy, when she's sad, when she's mad, and being able to then use other cards to be able to help her identify, did she need a hug? Did she need her blanket? Did she need to be rolled up in the bean bag? Or maybe somebody needed to help with some deep breathing as ways to help her find to regulate herself. One of the things that I wanted to talk about then is the importance of the child's history or the exposure in staying with the child. Is that important for the school to know? Families fear the implications of the child being labeled or the label being used as an excuse for the unwanted behaviors. And how do we expand emotional literacy in children, in young children or children with language delays? Looking at the identity of the feeling, being able to help the child identify the cause, and then being able to come up with a solution for self-regulation.
Fantastic. So now what we are going to do is it's your guys' turn to share those things. We're going to put you in 3 breakout groups, and Becca and Tressa, you will be taking, Tressa, will you pull up your community
I'm trying to find you.
Oh, will you pull up your community discussion slide again?
Sure. Sorry. Yes.
Sorry, I just don't have yours pulled up.
Is it still presenting? Okay.
Yep. So Becca, Becky, and Tressa, you guys are going to be talking about in your group, what's the importance of the child's history or exposure when entering school? And then in Natalie and Kurt, you guys are going to be talking about how do we help families oh my gosh, I can't say that word today, without letting it become an excuse for unwanted behavior. So I'm just going to skip over it. That was like my third time trying to say that word today. And then in Tiffany and Crystal, you guys will be talking about how to expand emotional literacy in children. So we're going to take about 20 minutes and discuss those within your groups. Bailey is going to put us into breakout groups. Please take a minute and introduce yourselves and talk about those 3 topics.
Okay, and the room should be open, so go ahead and join if you see that, and if not, let me know.